we were informed that you stopped working at the state cardiac unit, right?
Mm-hmm.
So why? But before that, just explain your role at the cardiac unit and how often you were there, you know?
Okay.
So yeah.
So the cardiac unit is the only specialized unit for the state patients to provide cardiac care, and there's basically three services there. There is an adult cardiac service, which was under myself. I was the cardiologist running that branch of the cardiac service and providing all the consultations, all the procedures. I was there every day, but we had a theatre time twice a week. And then clinics for the state patients were run also twice a week, and then we used to go to the ward rounds in the hospital and see the patients in other departments. I was also training the junior doctors, and one of the cardiologists that is being trained, the first Namibian cardiologist, Dr Oliveira, is now finishing her training in South Africa, so she hopefully will come probably next year to join us. And then there were two other services, the pediatric service, so those are the cardiologists that treat the kids, the children with the heart disease, and the cardiac surgeons. And the cardiac surgeons operate the patients that either me refer to them for adult patients, or the pediatric cardiologist for the children. So that's the unit. The unit was established years ago, and in 2016, 2017 we really had an extremely high activity, both in terms of procedures that we perform. We are doing about 1,000 procedures a year there, which is a very high number per unit, even compared to other African countries, with very good results. And the surgeons operated a lot of patients too. But as I said, since 2018, the number of activities started to decline significantly.
Okay.
Okay, so the reason why I decided to leave the hospital, there were several reasons. One of the reasons was obviously the high workload. At the height of activity, I was running both the units in the Roman Catholic, the private one, and the state hospital, the state one, and we were performing almost 2,000 procedures a year. For comparison, the average cardiologist in the UK is doing 100 to 150 procedures like this a year. So it was a hectic schedule, plus we opened the heart attack center at Roman Catholic Hospital, and at times there were patients arriving at the same time to both sites, so I had to quickly do one patient at the state and then quickly drive here and do the other patient here. So it was a really hectic schedule. But the main reason for stopping working there was that since 2018, due to the financial crisis, the financial support of the unit started to dwindle or diminish almost completely. We didn't get any new supplies of materials. I started to use expired items and had to improvise. And in January 2020, after a near-miss accident caused by preventable technical failure, I just decided that I won't work there anymore, because you need to understand we are working with a patient who is conscious, beating heart, and if there is a mistake or technical problem, we can kill the patient on the table. So I wasn't prepared to take the risk anymore. And that's the reason why I actually quit in February 2020. Currently, there is no specialist in the cardiac unit to provide a specialized service for the heart patients, adult heart patients. So they are treated, attended to by junior doctors. But none of the current doctors that are currently available in the unit can actually provide the treatment of a heart attack or acute cardiac emergency, or even the general consultations. So there is no specialist service provided to the patients at the moment. And the other private cardiologists did not step up to help so far to the cardiac unit at the state hospital. So at the moment the service effectively ceased to exist. The claim that pediatric cardiologists can replace the adult cardiologists is false, obviously, because they are trained in a different specialty than we do. And cardiac surgeons also, they operate people who are referred to them by us, but they don't replace us. They don't treat acute heart attacks, they don't treat acute emergencies, they operate. So obviously with the departure of a cardiologist, the cardiac surgical frequency of cardiac operations is also going down. They are currently operating mostly pediatric patients because the pediatric cardiologist is still there.
Health Executive Director Ben Nangombe told the Namibian last month that there is no cardiologist to attend to state adult cardiac patients.
He also said that there is a Namibian trained adult cardiologist completing training in Cape Town and will soon return to Namibia.
Well, that statement is misleading. There is no such things. Patients are simply not treated. There is nobody coming from external sector at all. So, so there is nothing happening. People are calling me and asking me where, or blaming me even that I abandoned them. But I knew that the situation would be like that when I was leaving the unit. That the service will not be provided, and it is not. So, at the moment, the service simply doesn't exist. But knowing that that might happen when I leave, I have asked Roman Catholic Hospital for assistance, for help, and several months ago we have offered the ministry the solution, which would be like this. If the patient, adult cardiac patient needs either emergency or even planned procedure, they would be admitted and treated at Roman Catholic Hospital. And this would be free of charge on my part. I wouldn't charge any fees for that. And even Roman Catholic would charge just the cost of materials and equipment. And then I would provide also once a week a walk-in clinic for the state patients, again free of charge. So more or less we would actually replicate what was happening in the state unit before, and even more, because we are here 24/7. So effectively the people will now have a 24/7 access, which wasn't the case in the past in this state hospital. You couldn't do the emergency any day, but here we are actually able to do so. So there will be improvement in access to this specialized care. Plus, I think it will be much more cost effective as well. I think we would be probably able to provide the service at a cheaper cost compared to what was provided at state unit. Because in private hospitals we really carefully look into who is supplying us, how much we pay for the equipment, for supplies. Frequently at state hospitals the suppliers are overcharging and the government is forced to pay inflated prices. So based on this data, I think we would be able to provide much better cost-effective service for the state patients virtually tomorrow.
Have you taken this solution or proposal to the ministry, and was it rejected? What was the actual progress of this discussion?
Well, we have submitted the proposal to the ministry some months ago, but we haven't received any reply so far. So we are still waiting for the decision of the ministry. Obviously, the time is of the essence here, because the patients are attending the Katatura casualty or other state hospitals, not just the Windhoek. It actually applies to the whole country. We used to accept the patients from all over the Namibia, obviously, from the north, from the coast, from the south, from everywhere. So that channel is now blocked, and we are just waiting for the decision of the Ministry of Health, either to accept this protocol or this program, or to come up with some other solution.
And sorry, how long ago did you propose this to them? Was it when you left, or?
No, I had to first prepare the program and negotiate with Roman Catholic Hospital, because obviously they have to agree that they will not charge any fees other than cost of materials. So we submitted the proposal, I think, 2 months ago.
Okay.
Yeah, we are here anyway. We can absorb the patients from the state at any point. It is not a problem for us to we have a capacity. We have a team. We have a surgeons here standby also. So actually, we are ready to go at any moment, and the patient would receive a very good service, I think. I don't think that you can actually provide the same service at the state hospital under the current circumstances, with the current scarce of skills situation that we have. And even if you have 1 or 2 specialists coming back from South Africa, which is not going to happen this year, they still will be alone there. They still need all the support that we have here. So I think personally that public-private partnership in the healthcare is going to be inevitable. Remember, the COVID-19 epidemics decimated the private sector now. There will be many people who will lose their jobs, and they will lose their medical aids. They will become state patients. So the pressure on the state is going to increase only.
Yeah.
Why not utilize the expertise that is already in the private sector? As long as it is not at inflated prices, as long as it is done with a high quality, and the patients, state patients, are treated equally as the private patients. I think that's the essence of it. And look, there is a private doctors which are coming, to private sector, which is effectively overserviced. There's many specialists that have come to Namibia recently to private hospitals, but nobody is really helping the state. And that situation should have been addressed a long time ago. One of the reasons why state hospitals are suffering from various problems is that there is no senior staff, senior medical staff, there is no senior consultants available. And the junior doctors are trying to provide the healthcare to the best of their ability and skills, but they are not trained, they are not specialized. So that's why I think partly we have this problem in the state system. If there was a rule that the incoming specialists should provide some help, doesn't mean that they have to work only in the state hospital, but 1 or 2 days a week or 1 or 2 sessions a week would make a huge difference to the state patient's care. But in the absence of that system, why not using the specialists in the private hospitals to provide the care in a carefully controlled manner?